Hello, I'm Dr. Eli Whitney with the Heart and Vascular Institute of Texas. I want to talk to you about homocysteine, a recently discovered important risk factor for the development of heart attacks and strokes. Part of our metabolism involves the breakdown of food that we eat. Homocysteine is a breakdown product of proteins. Homocysteine is an irritant to the internal lining of our arteries. The greater the homocysteine level, the greater the irritation, and this can become a problem. When the internal lining of our arteries is irritated, it's much easier for cholesterol in our blood to pass into the walls of our arteries. This not only accelerates the cholesterol blocking process, but also increases the risk for heart attacks and strokes. We first learned about homocysteine about 25 years ago when it was found to be in extremely high levels in children who died of heart attacks and strokes before the age of 10. Fortunately, this problem is a very rare inherited disease and only occurs in about one child in several million. The fact, though, is that homocysteine levels in these young children were in the hundreds, while safe levels are below 10. About 10 years ago, we noted that some young men and women aged 30 to 40 with heart attacks had homocysteine levels between 30 and 40. The average blood level of homocysteine in people with heart attacks is roughly 12 points, which is 4 points higher than the blood levels of homocysteine in people without heart disease. Hence, for every level of cholesterol, blood pressure, and the like, the higher the homocysteine, the greater the risk of developing heart disease. The likelihood of survival in those with heart disease is clearly influenced by the homocysteine level. In the EAST study, medical researchers looked at the risk of death from cardiovascular disease and all causes of death in a group of patients with heart disease who were treated with either bypass surgery or balloon therapy. They separated patients into 4 equal groups based upon their homocysteine levels. Patients were then followed for 8 years. The risk of dying from all causes was 9% in the patients with the lowest levels of homocysteine, 26% in the next highest group, 35% in the next group, and 30% in the group with the highest homocysteine levels. Cardiovascular deaths were 6% in the lowest group, 20% in the next group, followed by 27% in the third group, and 47% in the group with the highest homocysteine levels. Homocysteine levels can be lowered easily in many patients by using a combination of folic acid and vitamins B6 and B12. In the Swiss heart study, 500 patients who were treated with a balloon angioplasty were split into 2 equal groups. One group received vitamin therapy with 1 milligram of folic acid, 400 micrograms of B12, and 10 milligrams of B6 per day for 6 months. The other group received a placebo. After 1 year, repeat angioplasties were required in 16% of the placebo group, compared with only 9.9% of the patients who received the treatment to lower homocysteine levels. Fatal and non-fatal heart attacks, bypass surgery, and balloon therapy were required in 22.8% of the patients who received the placebo, compared with only 15.4% of the patients who received folic acid and B vitamins. Based upon these studies, most cardiologists now recommend that homocysteine levels be checked in all vascular patients. Those patients with homocysteine levels in excess of 10 are encouraged to take combination vitamin therapy with folic acid, B12, and B6. This therapy is very inexpensive, it's safe, as well as effective in reducing the risk of future cardiovascular events. I hope this educational program has helped you better understand the importance of homocysteine and why I recommend a vitamin therapy with folic acid, B6, and B12. I'm Dr. Eli Whitney with the Heart and Vascular Institute of Texas.